Have you ever been on a plane, felt that building pressure in your ears as you descend, and just wished it would pop?
Oh, yeah, that feeling.
Or maybe you've had a child wake up middle of the night clutching their ear in pain and you just felt, well, helpless?
Very common.
If so, you are definitely not alone. These experiences are incredibly common, and they offer a glimpse into the surprisingly delicate, often complex world happening inside our ears. Welcome to the Deep Dive, where we take your sources, peel back the layers, and extract the most important nuggets of knowledge, helping you get truly well-informed fast.
Yep.
Today, we're going on a journey into the fascinating and sometimes painful realm of middle ear disorders.
That's right. We're drawing from detailed medical excerpts that really break down the different conditions affecting the middle ear. Our mission for you today is to unpack these conditions, understand their causes, symptoms, treatments, and give you a clear, well-informed perspective on something that impacts so many, especially children.
And why it's so important to understand.
Exactly. Why understanding this often hidden world is so important.
Okay, let's unpack this then. Maybe start with one of the most common issues, something you've likely heard of. Acute Suppurative Otitis Media, or ASOM. What exactly is this, at its core?
Right. So ASOM, at its core, it's an acute inflammation of the middle ear.
Yeah.
Specifically caused by what we call pyogenic organisms.
Pyogenic, meaning?
Pus forming. Yeah. And when we talk about the middle ear here, we mean the whole middle ear cleft. That's everything from the eustachian tube, connecting your middle ear to the back of your throat.
Okay.
All the way to the middle ear cavity itself, and even those tiny air cells in the mastoid bone behind your ear.
Ah, so it's all connected.
It's an infection that can spread pretty quickly through that whole interconnected system.
And, when we talk about ear infections, I always hear about kids getting them. Is that just anecdotal, or are they genuinely more susceptible?
You're spot on. ASOM is significantly more common in infants and young children, especially those from lower socioeconomic groups, the data shows. Typically, it starts subtly. Often it follows a common viral upper respiratory tract infection like a cold.
Ah, the common cold strikes again.
Exactly. That cold then kind of creates an opening, a pathway for these pus-forming bacteria to invade the middle ear.
Okay, so if a cold sets the stage, how do those bacteria actually get into the ear? This seems like a, crucial point for prevention.
It absolutely is.
Yeah.
And here's the key insight. The most common route, by far, is via the eustachian tube.
Right.
Now, this is particularly relevant for children because their eustachian tubes are quite different from adults. They're shorter, wider, and much more horizontal.
Ah, okay.
This tiny anatomical difference, it acts almost like an open highway, making it far easier for infections to travel from the nasopharynx, the back of the nose, and throat directly into the middle ear.
So those tubes are basically an express lane for bacteria in kids. Does something as simple as how you feed an infant play into this?
It genuinely does.
Yeah.
For example, if an infant is breast or bottle-fed, lying completely flat horizontal, fluids can actually be forced through that shorter, wider tube into the middle ear.
Wow.
That's why keeping the infant propped up, head slightly higher, is often recommended.
Makes sense.
Similarly, swimming and diving can sometimes force water through the tube. Less common routes, things like traumatic perforations of the eardrum, that creates a direct opening, or even rarely, blood-borne infections.
Got it. Beyond the eustachian tube shape, what other sort of predisposing factors can set the stage for these infections?
Well, anything that interferes with the normal working of the eustachian tube can create a perfect storm, really.
Like what?
This includes recurrent common colds, other upper respiratory tract infections, even common childhood illnesses like measles, diphtheria, or whooping cough.
Okay.
Infections in the tonsils and adenoids, those lymphatic tissues back there, they're big culprits, as are chronic rhinitis, sinusitis, or persistent nasal allergies.
So lots of nose and throat issues.
Exactly. In some cases, more serious things like nasopharyngeal tumors or even temporary blockages from, say, nasal packing for nosebleeds can contribute.
Right.
And for children, conditions like cleft palate, where the roof of the mouth isn't fully formed, that can also be a significant factor because of how it affects the tube function.
Okay. So once that pathway is open, what are the main bacterial suspects we're looking at?
In infants and young children, we typically see three main culprits. Streptococcus pneumonia, that's about 30%. Then Haemophilus influenza, maybe 20%. And Marexella catarrhalis, around 12%.
Okay.
It's worth noting, though, about 18 to 20% of cases show no bacterial growth in cultures.
Really? So it could be viral?
Could be viral or just resolved by the time of testing.
Yeah.
What's also crucial for treatment is that many strains of H. influenza and M. catarrhalis produce something called botulactamate.
Beta-lactamate.
Yeah, think of it as a bacterial defense mechanism. This enzyme actively breaks down certain common antibiotics, like penicillin-based ones.
Making them less effective.
Exactly, making them less effective against the infection.
That's really vital information, isn't it? Especially for parents whose child might not be responding to the first antibiotic they try.
Absolutely.
So ASOM isn't just one static thing. It actually progresses through distinct stages, right? Like a journey of an ear infection. Can you walk us through that?
Yes, it's a pretty clear progression. It starts with the stage of tubal occlusion.
Okay, occlusion, blockage.
Right. Swelling, or edema, and increased blood flow, hyperemia, at the throat end of the eustachian tube blocks it. This causes the air in the middle ear to get absorbed, creating negative pressure.
So it sucks the eardrum in.
Exactly. The eardrum gets sucked inwards, or retracted.
Yeah.
Symptoms at this point, typically mild deafness and earache. And importantly, usually no fever yet. It's that feeling of your ear being blocked or plugged.
Got it. That initial uncomfortable pressure, then what happens?
If that blockage persists, you enter the stage of presuppuration.
Presuppuration, before the pus.
Precisely. This is when the pus-forming organisms truly invade the middle ear cavity, causing significant inflammation. Inflammatory fluid, or exudate, appears, and the eardrum becomes intensely congested, red.
And the symptoms get worse.
Much worse. Symptoms become much more pronounced. A marked, throbbing earache that often disturbs sleep. Adults might notice ringing, tinnitus, along with deafness. In children, you'll often see a high fever, restlessness.
And visually?
Visually, the eardrum can take on a distinctive cartwheel appearance. You see these blood vessels becoming strikingly visible along the malleus handle, that little bone handle, and around the edge, the periphery.
That sounds pretty awful. And I gather it gets even worse before it potentially gets better.
Unfortunately, yes.
So,
Enter the stage of suppuration. This is marked by the actual formation of pus in the middle ear, and sometimes even in those mastoid hair cells behind the ear.
Okay.
The eardrum starts to bulge significantly under the pressure of the pus. Sometimes it's bulging so much it's about to rupture. The earache becomes excruciating. Deafness increases. Children can run a very high fever, maybe 102, 103 Fahrenheit, potentially with vomiting, even convulsions in young kids.
Jeez.
On examination, the eardrum looks fiery red, severely bulging. The normal landmarks are often lost. You might even see a yellow spot where it's about to burst. X-rays would show clouding of those mastoid hair cells because of the fluid.
So the body's just desperately trying to get that pus out. What happens when it finally does, or when treatment intervenes?
Right. That leads to the stage of resolution. The eardrum ruptures, or, proper treatment is started early enough, and the pus is released.
Relief.
Immediate and dramatic relief, usually. The earache subsides, the fever comes down, the child starts to feel much better.
And the discharge?
You'll initially see a blood-tinged discharge. Then it becomes thicker, opaque, mucopurulent. Usually a small perforation, a tiny hole is visible, often in the lower front part of the eardrum. Gradually, the eardrum returns to its normal appearance, often healing completely.
But what if it doesn't resolve? Maybe because the infection's really bad or treatment was delayed. What's the worst-case scenario?
That's the stage of complication. If the infection is particularly virulent, or the patient's immune system is low, the disease can spread beyond the middle ear.
Spread where?
It can lead to very serious, even life-threatening conditions. Things like acute mastoiditis, that's infection of the bone behind the ear, facial paralysis if nerves get damaged, meningitis, infection of the brain's lining, or even a brain abscess, a collection of pus in the brain.
Wow.
This is precisely why it's so crucial to treat this condition thoroughly and promptly.
Right. And that brings us squarely to treatment. What's the main approach to stop it getting that serious?
Antibacterial therapy is the cornerstone. It's indicated for all cases with fever and severe earache.
Which ones?
Common effective drugs include ampicillin and amoxicillin. If there's a penicillin allergy, alternatives like cefaclor, cotrimoxazole, or erythromycin are used.
And what about those resistant bacteria you mentioned, the beta-lactamase ones?
Right. For those lactamase-producing strains, antibiotics like amoxicillin clavulinate, you might know it as Augmentin, or cefuroxime acetyl, are often prescribed because they can resist that enzyme.
Okay.
But what's absolutely vital here is the duration. Therapy must continue for a minimum of 10 days.
10 days minimum, even if they feel better.
Even if symptoms subside sooner. This is a key insight because stopping early is a major risk factor for later problems like persistent fluid secretory otitis media or even residual hearing loss.
So finish the course. It's not just about getting rid of the pain. It's about fully clearing the infection to prevent future trouble.
Exactly.
Beyond antibiotics, what about just making the person feel better? Symptomatic relief.
Yes, very important too. Decongestant nasal drops like ephedrine or oxymetazoline help relieve that eustachian tube swelling.
Right.
Oral nasal decongestants, sometimes combined with antihistamines, can do a similar job. For pain and fever, paracetamol is common. If there's discharge, careful ear cleaning ear toilet with sterile cotton buds is important. And applying dry local heat can help with the pain.
And sometimes, even with meds, surgery is needed. You mentioned myringotomy.
Correct. Myringotomy, that surgical slit in the eardrum to let pus out, is indicated in specific situations.
Such as?
Like when the eardrum is markedly bulging with excruciating pain, or if there's incomplete resolution despite antibiotics and the hearing loss persists, or if there's persistent fluid in the middle ear beyond, say, 12 weeks, it provides immediate relief by draining the pressure.
Okay, so that covers the typical, albeit nasty, journey of an acute ear infection. But what about that really severe, destructive form you mentioned earlier, acute necrotizing otitis media? Is that just a worse version or fundamentally different?
It's a severe, thankfully rare form of ASOM, often seen in children who are already weakened by other serious diseases like measles, scarlet fever, or severe flu.
And what makes it necrotizing?
What makes it distinct is its rapid and destructive nature. It doesn't just inflame, it causes necrosis, tissue death. It can cause extensive damage to the eardrum itself, the surrounding structures, those tiny hearing bones, the ossicular chain, and even the mastoid air cells.
Wow, so much more damaging.
Yeah, usually there's profuse, thick discharge. The key here is early and prolonged antibacterial therapy because the potential for permanent damage is just so high.
Okay. Now, shifting gears a bit. While ASOM is acutely painful, there's another very common middle ear issue that's often silent but equally impactful, especially for kids. Otitis media with effusion, OME, often called glue ear.
Ah, yes, glue ear.
What exactly is this more insidious condition?
OME is insidious, meaning it develops very gradually, subtly. It's characterized by the buildup of non-purulent fluid in the middle ear. So not pus, like an ASOM.
Yeah.
It's often thick, sticky, sterile fluid.
It's glue.
Exactly. It's very common in school-age children,
Right.
typically 5 to 8 years old. And because it's not acutely painful, it can be easily missed.
If it's not pus from an infection, what's causing the fluid buildup? What are the underlying mechanisms for glue ear?
There are really two main things going on. First, a malfunctioning eustachian tube. It fails to properly aerate the middle ear, leading to negative pressure, and it also fails to drain the fluid that normally accumulates there.
Okay.
Second, there's increased secretory activity of the middle ear lining itself. Biopsies actually show an increase in mucus-producing cells. The middle ear essentially starts acting like a mucus factory.
A mucus factory in your ear. Lovely. So what causes that tube malfunction or this increased secretion?
Several factors can contribute. Eustachian tube malfunction can stem from adenoid hyperplasia, enlarged adenoids at the back of the nose.
Right. Common in kids.
Very common.
Yeah.
Chronic rhinitis or sinusitis, chronic tonsillitis, 2 enlarged tonsils, can mechanically obstruct the soft palate movements needed for the tube to open.
Okay.
In adults, here's a critical insight. Unilateral OME fluid in just one ear should always prompt a thorough check for nasopharyngeal tumors. It can be an early sign.
Good to know.
Palatal defects like cleft palate also contribute. Other factors. Allergies are a big one. They can cause swelling, obstruct the tube, and stimulate increased secretions.
Ah, double whammy.
Yep. Unresolved ASOM, where maybe antibiotic therapy wasn't quite enough, can leave a lingering low-grade infection stimulating more fluid. And finally, certain viral infections like adeno and rhinoviruses can directly invade the middle ear lining and trigger that increased secretory activity.
So with all that fluid, what does this actually feel like? Or how does it present, especially in children, if it's so insidious?
Well, the most significant symptom, and often the only one parents notice, is that insidious gradual hearing loss.
How bad?
It rarely exceeds 40 decibels, which means it can easily go unnoticed. The child might still respond to loud sounds, but miss softer ones.
And the consequence of that?
A serious consequence can be delayed or defective speech development. They're simply not hearing all the sounds clearly enough to learn speech properly.
That's a big deal.
It really is. Sometimes there are mild earaches or just a history of lots of colds, upper respiratory infections.
And what would a doctor...
On examination with an otoscope, the eardrum often looks dull, opaque, maybe yellowish, grayish, even bluish instead of that normal pearly white. The light reflex is lost, and its mobility is restricted when we try to puff air in.
Can you see the fluid?
Sometimes if the fluid is thin enough, you might actually see fluid levels or air bubbles behind the eardrum.
So how is glue ear definitively diagnosed then, if the symptoms can be so subtle?
Key diagnostic tests are essential. Tuning fork tests often show a conductive hearing loss sound isn't getting through efficiently.
Okay.
Audiometry, the hearing test, typically shows that 20-40 dB conductive loss. Impedance audiometry, or tympanometry, is really useful here. It's objective, great for infants and young kids who can't always cooperate with a standard hearing test.
What does that show?
It measures the eardrum's movement. With fluid, it shows reduced compliance, less movement, and often a characteristic flat curve, indicating fluid behind the drum. And X-rays of the mastoids can sometimes show clouding of the air cells because of the fluid.
Okay, so once it's diagnosed, what's the main goal of treatment for OME?
The primary aim is twofold. Get the fluid out and prevent it from coming back, because long-term fluid can cause damage.
And how do you do that? Medically first.
Medically, treatments include decongestants, nasal drops, or oral ones to try and relieve eustachian tube swelling. If allergy seems to be a factor, anti-allergic measures like antihistamines, maybe even nasal steroids, can be used.
What about antibiotics?
Antibiotics are useful if there's an underlying upper respiratory infection or if it seems linked to unresolved ASOM.
What about helping the ear clear itself? Any practical tips for aeration that listeners could try?
Absolutely. For adults, doing the Valsalva maneuver repeatedly gently, trying to exhale with your mouth and nose closed, that can help pop the ears and aerate the middle ear. For children, it's trickier. Specialists might use politzerization, gently inflating the middle ear with air using a special device, or eustachian tube catheterization, inserting a thin tube. But a simple practical tip for kids is giving them chewing gum.
Chewing gum.
Yeah. It encourages repeated swallowing, which naturally helps open the eustachian tube.
Clever. And if medical treatment isn't enough, or the fluid is really thick, that glue consistency, when is surgery considered?
Then surgical options come into play. The most common is myringotomy and aspiration of fluid, making that small incision in the eardrum and sucking out the fluid.
Right.
If the mucus is really thick, like actual glue, saline, or a mucolytic agent, something to break down mucus might be instilled first to thin it out. Sometimes 2 incisions are needed, using a sort of beer can principle to properly aspirate that really thick stuff.
Okay. And what if it keeps coming back?
If the fluid recurs despite myringotomy and medical treatment, then a grommet, a tiny ventilation tube, is inserted into the eardrum incision.
Ah, the grommet.
Exactly. This provides continuous aeration, letting air in and fluid out for weeks or months until it eventually falls out on its own.
Are there more extensive surgeries?
In more complex cases, perhaps with loculated fluid trapped in pockets or other issues, tympanotomy, exploring the middle ear, or even cortical mastoidectomy, a more involved bone surgery might be needed. And very often, surgical treatment of the underlying cause, like removing the adenoids, adenoidectomy, or tonsils, is done at the same time as the myringotomy, as they're frequently part of the problem.
Makes sense to tackle the root cause. Now, speaking of things that are stubborn and hard to treat, what about this concept of biofilm? I've heard that's a fascinating sort of nugget in understanding these chronic conditions. Can you unpack that?
Biofilm. Yes, it really is a breakthrough concept for understanding why some infections are so persistent.
What is it exactly?
Biofilm is basically a protective mechanism that bacteria use to survive and multiply. Imagine bacteria sticking to a surface like the lining of your middle ear, or even a medical device like a grommet, and then secreting this protective slime layer made of complex sugars, polysaccharides.
A slime shield.
Pretty much. It acts like a shield. It lets nutrients in for the bacteria, but critically, it stops your white blood cells, your antibodies, and even most antibiotics from reaching the bacteria hidden inside.
Wow. So that's why some infections just won't clear.
It's a key reason for bacterial resistance and persistent infections, yes. In ENT, biofilms are implicated in chronic OME, chronic sinusitis, tonsil and adenoid infections. They can even form on the grommets themselves, making them less effective.
So how do you deal with biofilms?
It's tricky. Prevention strategies include things like using antibiotic-coated tubes and maybe removing tubes promptly once they're no longer needed to reduce the surface area for biofilm to form.
Fascinating stuff. So, if glue ear, OME, goes untreated for too long, What are the potential long-term risks? The sequelae for a child's ear and hearing.
If OME isn't managed properly and persists for a long time, there can be significant long-term consequences, unfortunately.
Like what?
The eardrum, the tympanic membrane, can become thin and atrophic, kind of wasted away. This can lead to atelectasis, where it gets severely retracted inwards.
Okay.
There's a risk of acicular necrosis damage or death of the tiny hearing bones, most commonly the inguinals. This can significantly worsen hearing loss.
Right.
Tympanosclerosis can occur. That's chalky deposits forming around the ossicles, stiffening them up, which also impacts hearing.
More hearing loss.
Yes. Also, those thin, atrophic parts of the eardrum can invaginate, folding inwards to form retraction pockets. These can sometimes develop into a cholesteatoma.
Cholesteatoma. That sounds serious.
It is. It's a dangerous skin cyst that can grow destructively within the middle ear and mastoid bone. Finally, cholesterol granuloma, a type of benign cyst due to stagnant secretions, can also happen.
So, quite a list of potential serious outcomes from what can seem like just a bit of fluid. Really reinforces the need for early detection and management.
Absolutely.
What about recurrent acute otitis media? You know, when those painful ear infections just keep coming back again and again.
Right. That's defined as frequent episodes. Typically 4 or 5 times a year in children usually between 6 months and 6 years old. They often follow colds or other upper respiratory infections, and the child is usually completely fine in between bouts.
But sometimes they can happen on top of glue ear.
Yes. Sometimes these recurrent acute infections can be superimposed on existing middle ear effusion, complicating things further.
And what makes some kids so prone to these frequent bouts? What are the underlying causes?
Underlying causes can include things like recurrent sinusitis, velopharyngeal insufficiency, where the soft palate doesn't close properly against the back of the throat, which affects eustachian tube function.
Okay.
Adenoid hypertrophy, enlarged adenoids again, infected tonsils, allergies, or sometimes even underlying immune deficiencies.
And you mentioned feeding position earlier.
Yes. Here's that crucial connection for parents again, often overlooked.
Yeah.
Feeding babies lying flat, completely supine, without propping their head up, can allow milk to reflux up the eustachian tube and directly into the middle ear.
Leading to infection.
Exactly. It's a simple, actionable prevention tip. Keep the head slightly elevated during feeding.
Good practical advice. So given all these potential underlying causes, what's the management approach for these frequent frustrating bouts of ear infection?
Well, the first step is always trying to find and eliminate the underlying cause, if possible.
Makes sense.
Antimicrobial prophylaxis, giving a low-dose antibiotic like amoxicillin regularly, has been used, but it has drawbacks.
Like resistance.
Exactly. Promoting antibiotic resistance, potential hypersensitivity reactions.
Yeah.
It's not always the preferred long-term solution nowadays.
So what is preferred?
Many specialists lean towards early insertion of tympanostomy tubes, those grommets again, especially if a child has, say, 4 bouts in 6 months, or maybe 6 bouts in a year.
Right. Keep the ear aerated.
Precisely. And adenoidectomy, removing the adenoids with or without tonsillectomy, is often recommended too, along with careful management of any identified inhalant or food allergies. These often address the root cause of the recurrence.
Okay. Finally, let's talk about something many of us have personally experienced. Otitis media, also known as otitic barotrauma. That pressure pain on planes.
Ah, yes, barotrauma.
What exactly is this non-infectious condition?
This is a non-infectious condition, meaning no bacteria or viruses involved directly. It arises when your eustachian tube fails to equalize the pressure in your middle ear with the surrounding atmospheric pressure.
Like during landing?
Exactly. Most commonly experienced during rapid descent in air travel, or during underwater diving, or even compression in therapeutic pressure chambers. It's essentially a pressure injury to the ear.
How does that actually happen inside the ear? What's going on with the eustachian tube to cause that pain?
Well, the eustachian tube is designed to let air out of the middle ear relatively easily when external pressure is decreasing, like going up in a plane.
Right.
But when the external atmospheric pressure becomes significantly higher than the middle ear pressure, say, by a difference of 90 millimillimeters or more, like during descent, the eustachian tube can get locked. The soft tissues at the throat end of the tube get pushed inwards by the higher external pressure, effectively sealing it shut.
Ah, it collapses on itself.
Pretty much. And if there's already some eustachian tube swelling, maybe from a cold or allergy, even smaller pressure differences can cause this locking.
And the result?
This sudden negative pressure inside the middle ear sucks the eardrum inwards, makes it red, congested, Fluid can leak out from the tissue's transudation. You can even get tiny hemorrhages under the eardrum lining.
Ouch.
In rare, severe cases, the extreme pressure difference can actually rupture delicate membranes inside the inner ear, labyrinthine membranes.
Leading to?
That can lead to vertigo, dizziness, and even permanent sensorineural hearing loss, inner ear hearing loss.
Yikes. So what does it feel like for the person? And what would a doctor see if they looked inside during barotrauma?
Clinically, the main things are severe earache, hearing loss, and sometimes ringing in the ears, tinnitus. Vertigo is less common but can happen in severe cases.
And the eardrum?
On examination, the eardrum looks noticeably retracted, sucked in, and congested, red. In very severe cases, it might even rupture. Looking through the eardrum, the middle ear might show air bubbles, or sometimes a collection of blood-tinged fluid hemorrhagic effusion.
What about the hearing loss?
The hearing loss is typically conductive, meaning sound isn't getting through the middle ear efficiently. But as I mentioned, that inner ear sensorineural loss can also occur if those inner membranes are damaged.
So how do you treat this barotrauma once it's happened? Get the pressure equalized somehow?
Exactly. The main goal is to restore middle ear aeration, get that eustachian tube open again.
How?
This might involve specialized procedures done by a professional, like eustachian tube catheterization or politzerization, to gently force air up the tube.
And for milder cases?
For milder cases, decongestant nasal drops or oral decongestants, maybe with antihistamines, can be helpful to reduce swelling around the tube opening. If significant fluid is present, or if other methods fail to unlock the tube and relieve the pain and pressure, a myorotomy can be performed.
To drain the fluid or blood?
Yes, aspirate the fluid and immediately equalize the pressure.
Okay. This one feels particularly relevant for so many of us who fly or maybe dive. What are the best, most practical ways to prevent aerotitis media from happening in the first place?
Prevention is absolutely key here, and thankfully many strategies are very practical.
Good. Like what?
Firstly, if you can, try to avoid air travel if you have an active upper respiratory infection or bad allergies. That existing eustachian tube swelling makes you much more prone.
Oh, okay. Makes sense.
During descent, that's the crucial time swallow repeatedly. Sucking on sweets or chewing gum is genuinely useful because it makes you swallow more often, which helps open the tube.
Right.
Also, try not to sleep during descent because you naturally swallow less when you're asleep.
Ah, good tip.
Performing the Valsalva maneuver intermittently during descent, gently blowing out with your mouth and nose pinched closed, can help auto-inflate the tube and equalize pressure.
Got it.
If you have a history of this problem, using a vasoconstrictor nasal spray, maybe taking an antihistamine and a systemic decongestant about half an hour before descent can be very beneficial.
Pre-medicate.
Sort of, yeah. And finally, for people with recurrent issues, addressing any underlying problems like nasal polyps, a deviated septum, chronic nasal allergy, or chronic sinus infections is really important.
Tackle the root cause again.
Exactly.
Wow, what an incredible journey through the middle ear. From those acute, often really painful infections like ASOM, to the more insidious and silent glue ear, OMI, and even the pressure problems of barotrauma that so many experience. We've really seen how interconnected these conditions can be.
Yeah, they often link together.
And how a seemingly minor issue, like a cold, can sometimes escalate or lead to chronic problems down the line. Understanding these pathways truly helps you appreciate why certain preventative measures or treatments are so crucial, especially for children whose developing ears are just so vulnerable.
Exactly. This deep dive truly highlights how the body's delicate balance in the ear can be so easily disrupted, and why timely, thorough intervention isn't just about relieving pain in the moment, but really about safeguarding long-term health, hearing, and even development.
Absolutely.
Yeah.
So here's something to think about. Considering how vital early detection and consistent treatment are for these conditions, particularly in childhood, how might improved awareness and maybe implementing some of these simple preventative strategies we discussed truly impact the long-term health and developmental outcomes for so many children around the world?
That's a powerful thought.
Something to mull over until our next deep dive.